Good morning or good afternoon to all of you, and welcome to this webinar on osteoporosis burden and management, finding from the IOF Scorecard for Osteoporosis in Europe project. I'm Dominique Pierron, Science Manager at IOF, and I'm glad to moderate this webinar today. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted. I also would like to encourage you to ask your questions during the webinar by typing them into the question box of the control panel, and I will voice them to the speaker toward the end of this webinar. I would also warmly thank Amgen and UCB for their support to this webinar. This being said, I have the great pleasure to welcome today Professor Nicholas Harvey, who is Deputy Director and Professor of Rheumatology and Clinical Epidemiology at the MRC Life Course Epidemiology Center at the University of Southampton in the UK. He is also the chair of the IOF Committee of Scientific Advisors, and he is very active in many national and international committees and societies. He leads an MRC program focused on the life course epidemiology of bone and joint diseases, and he has published over 300 peer-reviewed papers. Professor Harvey, we are very happy to welcome you today, and we are listening to your presentation.
Thank you very much, Dominique, for that kind introduction. And well, it's a great pleasure to be with you today to just talk about the work of the Scorecard for Osteoporosis in Europe, which has been undertaken through the auspices of the IOF and with the support, as Dominique has described, to really get a feel for the burden of disease and the provision to tackle that burden across Europe. And so what I'll do over the next half hour or so is to give you an idea of the sort of history of this work, and this really reflects an evolving study over the last 10 to 15 years or so, and then take you through some of the findings across the burden of disease, policy framework, service provision, service uptake, and then a word on the scorecard itself. And what I'll try to do throughout this presentation is just at various points highlight some of the key issues in terms of the gaps in the care for osteoporosis and the ways in which we might overcome those gaps to do justice to the treatment of some of our most vulnerable patients. So the IOF has a long history of work in this area, and going back to initial assessment of the burden of disease and service provision in 2013 across the European Union as it was at that point. And then this, which is updated through the current work. And in 2016, we addressed a really comprehensive report on the gaps and solutions in bone health for the World Osteoporosis Day report. And that report really identified a number of areas in which osteoporosis treatment was suboptimal, and really issues at a whole range of levels around individual patients, around healthcare systems and society as a whole. And that's really complementary to the understanding of the burden and healthcare provision through the scope study. And I think if we just set this in the broader context of the burden of disease, so this is a figure from our Broken Bones, Broken Lives report, which is informed by a study of 6 EU countries. We published a couple of years ago as a sort of part of this anthology of work. And what this shows is that the long-term disability, so here encapsulated as disability adjusted life years, associated with osteoporotic fractures, is right up there with COPD, so chronic lung disease, he said appropriately coughing, lung cancer and dementia, but obviously lagging behind ischemic heart disease. And when we see that for a woman in her remaining lifetime from the age of 50 has a 1 in 2 chance of osteoporotic fracture, and for a man it's 1 in 5, this is a substantial burden of disease. And I think, you know, as making to policymakers this morning as a point, fractures, you know, for this audience, no surprise, but these are not trivial events, and that even a wrist fracture in an older, frailer person can be the thing that tips them into dependence and needing help. And a hip fracture may be the thing that tips them into institutional care. So there's often prolonged pain, disability, loss of independence, not to mention a 20% hit on relative survival with major osteoporotic fractures. And as we'll see across Europe, somewhere around a £57 billion annual direct healthcare cost. But of course, we mustn't forget the social care cost, which is really unquantifiable in current systems, but is massive. And you know, reflect things like carer time, loss of employment to the carers, and all those sorts of costs, which add substantially. And I think if we were able to capture them, would tip the already favourable economic models of treatment even more in favour of treatment. And so I think you'll appreciate that there's a massive burden of disease for individuals, healthcare systems and society. And that actually, even though we've made huge strides in osteoporosis care over recent decades, you know, going back 40 years or so, that osteoporosis is no longer viewed as an inevitable consequence of aging, but is a disease with a definition. You know, it has codes associated with fractures. It has good ways of assessing risk through FRAX and through numerous guidelines internationally, and has a really good range of treatments. But we're just not treating enough people and not identifying enough people. And we'll sort of go on to highlight some of those key issues as I go through the findings of the scope report. Excuse me. So I think one of the key points about the burden of disease is this is not something that's going away. So we can see in this, what is a WHO decade of healthy aging, that actually, you know, populations are aging. So that's the same across the world. So over the next 50, 100 years, the proportion of the population who are 60 plus, 80 plus is getting ever higher. And so even if age and sex adjusted rates of fracture remain stable, then we are going to see an increasing burden of fractures in coming decades. And I'm just going to turn off my microphone for a second to cough again. So I've had COVID not that long ago, so it's left me with a bit of a cough rather annoyingly. So looking at the burden of disease going forward, again, if we look at the number of high fracture probability individuals, so this is defined using a sort of FRAX approach, we expect the 150 million or so individuals at high fracture risk in 2010 to at least double by 2040. And you can see across the world that a lot of this increase is going to be in low middle income countries, and that societies have previously been thought, for example, in Africa and Asia, to be at low fracture risk as their sort of societies evolve in income terms and lifestyle changes. Fracture rates or numbers of fractures and the age and sex adjusted fracture rates are likely to rise, and with the aging, expanding populations as well. So an increase in the numbers of fractures expected across the world. So against that backdrop, a somewhat gloomy backdrop of increasing fracture numbers internationally, the aim of the scope work was to really provide an update to a number of fragility fracture metrics across the EU. And here it's the EU 27, and of course now sadly UK is one of the +2 along with Switzerland. And with a scientific steering committee, we developed a series of metrics to facilitate describing the burden and management of fragility fractures across Europe. And a working group performed the data collection analysis led by Fred Broadstrom at Quantify Research. And data were collected from current literature, available retrospective data and public sources. And at this point, I would say a huge thank you to the relevant national societies, so members of the IOF CNS, who were instrumental in providing information specific to individual countries, which were absolutely valuable to the production of the report. In terms of analyses, well, different methods were applied as you would expect to different sorts of metric. And these might have been standard statistics, health economic modelling, or whatever, but applied appropriately to get the figures out. So there were 4 domains: burden of disease, service provision, service uptake, and policy framework. And you can see the link to the paper there. You can get to that via the IOF website as well. And I would also say that there are now the country-specific reports for the individual countries, which are available as a massive compendium of reports in Archives of Osteoporosis. So if your country is involved, then you can get data on your specific country. And also the office have done a fantastic job of preparing individual sort of fact sheets for some of the individual countries, and that's work in progress. So what I'll do is just take you through some of the individual domains. So looking first at burden of disease around fractures and forecasts for the future. So if we look at the fracture burden and look at the costs associated with that, so in 2019, the direct cost of incident fractures was just over 36 billion. The ongoing long-term disability costs from fractures in prior years was 19 billion, and the cost of pharmacological intervention was 1.6 billion. And really, as we'll see, given the massive care gap, that should really be a lot higher, because that reflects the low percentage of individuals who are treated, who should be treated. But the total cost comes to somewhere around 57 billion euros annually, excluding the qualities lost, excluding the social care costs. And if we look at the numbers of fractures expected over the next 12 years or so, we can see that we're expecting an increase in all countries ranging from less than 25% to above 30%. And the average is somewhere around this 30% or so over the next 12 years. And in 2034, it's anticipated that 5.34 million individuals will be affected by an osteoporotic fracture, and that's about a 24.8% increase, so 1.06 million from 2019. And I think this is really quite a sobering slide. So if you do the calculations in Sweden, where we've got all the relevant data, and look at the deaths associated with various predisposing diseases, actually in women in blue and men in yellow here, fracture-related deaths are really right up there with cerebral vascular disease, lung cancer, approaching dementia, obviously behind ischemic heart disease, but a leading cause of death. And I think that's something that is really not very well appreciated, that actually fragility fractures are really serious. These are not just things that you go in a plaster cast for a few months and get better necessarily. These are things that have a major impact onto your remaining lifetime, maybe shortening it. So if we look at the remaining lifetime probability of hip fracture, and again, as with all of these metrics, it varies markedly by country. And we can see that the probability is quite high, ranging from around 7% up to 25% up here in the upper third of the distribution. So, and as expected, marked variation by country, reflecting what we know about the epidemiology. So if we look at policy framework, This is really looking around where osteoporosis fits in terms of prioritisation, management, specialist training, and patient organisations. We can see that actually the quality of the information on the epidemiology of hip fractures has improved since 2010, which reflects the institution of national hip fracture registries and other epidemiological studies, which is, I think, is all really good news. And but you can see across the board that it's still not perfect, but a good number. 14 countries have established national hip fracture registries, and they're really important towards gathering accurate prospective data. And in the policy meeting we were in this morning, we were really amplifying the message that having really good quality numbers around the burden of disease is really important when engaging with policymakers, politicians, and so forth, trying to change things. You need data to inform those discussions, and we're getting more and more of it, and more high quality data. That said, at the moment, osteoporosis is still rarely a national health priority. It is in 6 countries, so Finland, France, Italy, Poland, Romania, and Sweden. It's in terms of being a priority with action attached. It's a priority in Bulgaria, Germany, and Spain. But look at the vast majority of countries, it's not a priority in its own right. And clearly, that's a point at which we can really lobby, we can engage with our politicians and policymakers to try to get it up there on the agenda. And certainly, for example, in the UK Royal Osteoporosis Society, of which I'm a trustee, is very active in engaging with our UK all-party parliamentary group, and we had a similar discussion in a Finnish press conference around their all-party parliamentary group this morning. And that sort of venture where you bring together politicians, doctors, other healthcare professionals, policymakers in a sort of non-partisan grouping that hopefully can sort of look beyond the short term into the more long term, I think is a really important part of trying to alter policy longer term. And I think that links into sort of policy terms with the medical provision. And I think osteoporosis has a particular issue, which is highlighted by these findings from the SCOPE report, that actually in the majority of countries, osteoporosis is not a specialty in of itself. So it's not like rheumatology or endocrinology. But care of osteoporosis spans all sorts of specialties. So, I mean, you see the majority of the sort of bigger ticket ones here: rheumatology, rehabilitation, orthopedics, internal medicine, gynecology, geriatrics, and endocrinology. But actually, it's even more complicated than that, because, for example, in many countries, orthopedics will see the fragility fracture, but won't sort out the osteoporosis care. And in the UK, that's very much, well, as in many countries, that's very much what fracture liaison services are about, where you bring together the orthopedics of managing the fracture with the rheumatology or care of the elderly or endocrinology of managing the osteoporosis and the reduction in fracture risk. And this is an issue because, of course, if you've got different specialties managing the disease in different hospitals, you'll get heterogeneity of care, of approach, and the sort of inclusion of osteoporosis in syllabus of training in different specialties is variable. Sort of certification in osteoporosis is variable. So across all of these things, that there's ample scope for what we call in the UK a postcode lottery, where the care you get depends upon where you live. Of course, that's within countries and across countries. And it's something that it's clear that more uniformity is needed to help close care gaps and ensure uniformity of care. So building on that theme around service provision, we've talked about the services, the specialties that might provide care, but what about the care itself? Well, DXA is, of course, a major cornerstone of osteoporosis risk assessment. And actually, you can see that the coverage per million of population for DXA is pretty poor, ranging from really rather low coverage in places like the UK, sadly, up to very good coverage in other countries, as shown here. And of course, it's not quite as simple as a sort of averaged out care per million people, because in many countries, populations are concentrated in specific, usually sort of urban areas, where you may have good provision, but then in more isolated rural areas, there may be very few DXA units. So it's not that these things are sort of uniformly set out across a country. And I think that's something we need to factor in. So even if something looks good overall, it may be that there's still areas of countries which are not covered well. But about 60% of countries had the minimum recommended number of DXA machines to the population, which is around 11 DXA units per million. And of course, one can quibble about what is the actual best number, and to a certain extent it's arbitrary, but that's where the threshold has been set. There's not actually been that much of an increase in DXA equipment, and of course populations have expanded as well, so DXA numbers need to expand markedly to keep up as well. So in terms of the of other aspects of care, so DXA is sort of common to both primary and secondary prevention, but fracture liaison services are of course the cornerstone of risk assessment where one has actually had a recent fragility fracture. And here, I mean, you can see that really coverage is pretty poor across the board. So only really 6 countries, Finland, Ireland, Malta, Netherlands, Sweden, UK, have really good FLS coverage, or at least good in the sense that it's more than 25% of hospitals, which is clearly not good in the sense of it being optimal. Poor coverage, a lot of hospitals, no FLS in really quite a substantial number. So clearly, despite the sterling efforts of individual countries and of course of the international leadership of Capture the Fracture, which is ongoing and is actually adding FLS daily, it's over 600 now, I think, in a large number of countries. So fantastic efforts. It's just that the demand out there is vast, and clearly this is a work in progress and more is needed. So what about service uptake? And I think this is a really telling set of metrics, and I think inform that concept of the gaps in the provision service. So quite what constitutes the benchmark for FRAX usage, I think, again, is arbitrary, but we can see that, as with all the other metrics, there's quite a marked heterogeneity. And of course, there are how one uses FRAX in a particular country depends upon the national guidance as well. And it may be, for example, in Germany, the guidance doesn't really use FRAX as part of it. And so there's heterogeneity in the place of FRAX within national guidelines. But we can see that the usage can be really very high in various countries. And for example, in the UK, our national osteoporosis guideline group guidelines are linked explicitly to FRAX. So of course the sessions used is very high there. But often FRAX is underutilized compared to DXA, for example, in Denmark. And so bringing those two things together is quite an interesting way of trying to benchmark the sort of relative approach to risk assessment. But I think the thing that, I guess if you take away one thing from this talk, it's around the treatment gap in Europe. And this is the percentage, I mean, shown here, of European women, although we suspect that the figures, although not so easily quantifiable, are similar for men, that on average 71% of women who are at high fracture risk do not receive appropriate assessment and treatment. And you can see that this goes even higher in some countries, and even at best is probably not optimal. And this really highlights that, despite the massive advances we've made in primary and secondary prevention, we're still hit by the under-prioritization, by perhaps the perception of patients that, fracture's a one-off thing, or it's just because I'm getting older, what do you expect? Or, well, I fell, what do you expect, kind of thing. So it's not something they're clamoring to get preventative treatment for. Maybe, as in over the last 10 years or so, misplaced and over-exaggerated worries and sort of media portrayal of rare but serious side effects, and even physicians not standing up for the benefits versus the risks, and guidelines unhelpfully, for example, in the UK, multimorbidity guidelines talking about reassessment after 3 years with the implication that you might not want continued treatment. So I think the general sort of mood music out there and environment has been very difficult for osteoporosis care and ensuring that people are sufficiently treated and getting on treatment in the first place, and then adhere to treatment longer term. And I think it's beholden upon us all as osteoporosis physicians to really engage with this and try to get awareness up and engage with national campaigns, engage with policymakers, and educating our patients and the population at large through national societies and so forth to really try to get to close this care gap. And I think a really important point here is around the systems that we have to identify people at high risk. And that's something that is very much a priority of the IOF through the Epidemiology and Quality of Life Working Group. Links very nicely to some work that we're doing in the UK through our MRC Centre and the Royal Osteoporosis Society, and the Royal Osteoporosis Society Research Academy. And it's really around screening and around automated risk assessment in primary care. And to my mind, being able to identify people automatically through what we know about them through their primary care records, or in other countries, for example, through insurance healthcare records and providers, to automatically flag up people at high risk and warranting assessment and treatment, and taking some of the serendipity and chance out of it would help really achieve a step change. And a position paper on screening and systematic risk assessment led by Eugene McCluskey and colleagues is making its way towards publication, and I think will be really helpful in setting out that vision for the way forward. So that's sort of taken me towards the end of the individual metrics. This is gone on too far. So the scorecard itself looks like this. So what we've done is against the metrics which are able to be scored in terms of a sort of numerical threshold for amber, green, red, and so forth, or black where we're lacking data. We've put them together for the scorecard, so you can see, look at your own individual country and see how that's rated against other countries. And we hope that this will be a helpful series of metrics to enable individual clinicians and groups and policymakers to, in their own country, lobby for change and try to improve things for our patients. And in terms of the comparison with the previous scope 2010, 15 of the 16 scorecard metrics were used in both surveys, and they'd improved in 15 countries, remained constant in 8, and worsened in 3. So I think this all looks encouraging, but actually, as I've really shown you, the gaps are still there. And there is clearly an enormous amount to do by us as interested parties, us working through our national international societies, lobbying our governments, and engaging with all party parliamentary groups and this sort of activity to get the message across. And I think we really, just in finishing, I think we need to engage at all levels. So we need to engage in ways to alter policy and our clinical approach, that we can successfully case find, we can successfully screen as the next stage of the journey. to pick up people at high risk of fracture before they're fractured, to successfully identify people who have fractured through fracture liaison services, and efficiently link those up with pathways towards assessment and treatment. We need to be able to ensure adherence to medications. Adherence is awful. It's pretty awful for most chronic diseases in preventive terms, but it's that's a scant comfort if you're in a particular disease area. We need to find better ways at enhancing adherence. We need to ensure public awareness, not just of the importance of medications and staying on them, but also education around the appropriate assessment of benefit and risk. And for example, we're going to be releasing a new tool from the IOF and our colleagues in the US around Bone Health Foundation around a new way of just a tool of helping patients understand risk, or helping physicians to educate patients about risk, called the Radically Simple tool. And sort of ventures like that to help the understanding of risk, I think, is going to be really important. And then finally, it's really approaching the politicians and understanding the health economic arguments and making the case for the investment and that longer term view of funding, so that it's not completely bound up in this year's budget and bottom line, which I think is often where it gets stuck. And of course, there's issues of elections, and that's of course maybe an issue in the long-term thinking of politicians. But I think the more we can individually as countries provide to our own policymakers, unify the message between societies and unify that message over a long-term period, I think is really important. And it's only with that sort of joined up, working and collaborative and unified message that we're going to be able to achieve something for our most vulnerable patients. So with that, I will finish, and thank very much Dominique for her help with chairing. Thank very much our sponsors, and Dominique will say about a word about that in a minute. And I look forward to the discussion. Oh, and do join us at the virtual Congress, which is next week, I think. So lots of good stuff there. So if you haven't signed up, I would urge you to do that. So question and answers.
Thank you very much, Professor Harvey, for this very comprehensive presentation. I really enjoyed listening it, and I'm sure it was also greatly appreciated by our audience. And now I would like to move on to questions. Maybe I will start with the first one while people are typing their questions. I know from the report that the treatment gap has increased in some countries over the last decade. Can you try to explain why is it happening?
Yeah, I mean, I suspect it's multifactorial, and I'm sure it will differ between different countries. I think it's really the sorts of issues that I've outlined, and I think if you look at the different levels, I think in some countries it will be a policy, sort of change in emphasis in policy, and of course, there's in a world of constrained resources, and with COVID and everything else, it's increasingly constrained. We're sort of in a world where we've got to compete with other specialties and other diseases, and I think that there's very much perception. Of course, cancer and heart disease are the sort of leading players, and they tend to get much more awareness in terms of policymakers and patients. So I think there's that sort of backdrop. I think there will clearly be some specific issues in specific countries, but I think the issue around perception of risk and the sort of worries around the medications, I think, has been quite a big issue as well, and certainly it's the same in the US as well. But big concerns, misplaced concerns, given the rarity of osteonecrosis of the jaw and atypical femoral fractures, but sort of scare stories around bisphosphonates and these outcomes. And when, as the colleagues in the US have done, where you sort of plot out the Google searches for those things, you can see that, or around the alendronate, say, you can see peaks around when big newspaper stories have come out. And certainly, in my metabolic bone clinic, a lot of the time is spent with patients who are really, really upset about very, very unlikely side effects, much more than they are about the risk of having a fracture. And so I think the work that we're doing, so Michael Hillisman, for example, is leading in terms of understanding ways of communicating risk with Stuart Silverman as well, in a project through our epidemiology and quality of life working group. I think understanding better how we can communicate risk to patients is really important. And I think finally, it's having the processes there that can facilitate identification of people at risk. And certainly in the UK at the moment, and primary care is just getting hammered by a lack of funding, everyone being oversubscribed, too many priorities that they're supposed to attend to. And so getting any one disease area up the rankings to be sort of identified, I think is quite hard. So I think it's multifactorial. And within each country, we need to really hone down on what the barriers are and how they can best be addressed.
Thank you. So now Dr. Tian Tuli is asking how many people do we need to treat to save one hip fracture or another type of fragility fracture?
Oh gosh, well, I think that's how long is a piece of string, really, because it depends on the the risk in your individual country. So I think it would be misleading to give a number. But I think when one looks at when one does the health economic studies, I mean, it's clearly, particularly with bisphosphonates being generic and so cheap now, I mean, it makes absolute sense and health economic sense to treat at the sort of thresholds espoused by, say, the NOG guidance, where you're using a FRAX probability at the level of somebody who's had a prior fracture, and I think that's probably the way to look at it. And I think a number of guidelines are formulated around that. So yeah, I mean, I think an individual number will just vary according to the risk in your individual population. But I think in most populations, it makes complete sense to do that, and it makes health economic sense across the board to treat on the basis of a fracture risk in the way that most guidelines have outlined it, to be honest.
Thank you. Now I have a question from Professor Czerwinski from Poland. He's asking if a single number could be generated as a total assessment of the situation in a given country based on the colored dots in the scorecard.
Yeah, that's an interesting thought. Well, I mean, undoubtedly it could. I guess there's no reason why one couldn't just look at them and add them up in some way. So yeah, I mean, I guess we've tried to sort of portray the scorecard graphically so one can see the individual colours. I think a single number would obviously hide a certain amount of detail. You wouldn't know whether you'd scored well in particular areas. And I think it's probably quite important to appreciate whether a country, where the issues are in that country, and whether it's with the service provision, or whether it's with service uptake, or whether it's with burden of disease. Because of course, low spending on osteoporosis could be that there are no fragility fractures, or it could be that there are loads, but nobody ever gets treated, for example. So I think, to me, the nuance is important. I probably wouldn't want to sort of reduce it down to a single number, but I'm sure it would be possible.
Okay. So I think we have no more question unless there is somebody just would like to type a final one. Otherwise, I think it's time to conclude. No, sorry, there is one more question coming.
Stick it back on the Q&A slide then. Yeah, okay.
Yeah, no, people are asking questions, so sorry.
Oh, good, thank you.
Two more, but one short one from Dr. Grigori. Is the treatment gap dependent on the presence of FLS?
Yeah, well, I think it will be overall, and I think it's difficult to. It depends what you mean by that, but yes, the way that it's modelled is to use the demographics of the country and what we know about the fracture risk factors in countries to estimate the proportion of the population who would be at high risk of fracture, and then look at the rates of prescription within that country. So it's, this is not a this is a modelling approach. Clearly within that, some people would have been through an FLS. This is not based on a sort of individual, Mrs. A, we know has broken something or hasn't broken something and has or has not had treatment. It's a sort of aggregate data based on prescribing, on drug sale to that country, and modelling the burden. I think in terms of addressing the treatment gap, absolutely. I mean, FLS is clearly part of that, and we know that if you look at the picture as a whole, regardless of whether people have had a fracture or not, there's a massive gap. If you look at the gap in terms of people who have already had a fracture at some point, it's massive. And even after a fragility fracture, where you think that people should be treated, there's still a big gap. I mean, in the UK, for example, around after a hip fracture, in a recent study from several years ago now, it was only up to about 30 or 40% treated. And okay, it's never going to be 100% because it's never going to be appropriate to treat everybody, but it should be a lot higher than that. And so even in secondary prevention, there is a gap. And so I think across the board, we need to be closing the gap.
Okay, thank you. Dr. David is asking that, how, when you're following a patient diagnosis of poor bone health prior to osteoporosis, how can we improve the poor reinforcement by the medical profession on the need for appropriate medication, monitoring, and adherence to medication?
Yeah, well, that's probably a whole another series of seminars, probably not best given by me, but it's difficult. And I think, I mean, you've absolutely hit the nail on the head that this is an absolute key question. And I think part of it is how one communicates risk. Our major problem, for a lot of this, is that we have diagnosed people with a problem, but they can't feel it, they're not suffering, they haven't had a fracture. What is my problem? Why should I take this tablet once a week, for which I have to get up early in the morning, and it interferes with my breakfast, my cup of tea, and gives me indigestion? Why should I do that when I don't have any problem? All you're telling me is this number on this scan is a bit low, but what difference does it make to me? So I think trying to get people to take prophylactic medication where they don't have a sort of tangible end event yet is difficult. Blood pressure would be the same, and hypercholesterolemia, for example. So I think being able to communicate risk more effectively is important. And as I said, there's studies ongoing about that. And if we can nail how to help people to understand risk, I think that will help in that education. I mean, I don't know how well we will succeed in that, and of course everybody's different, and we're all time poor in our clinics, and actually you need to spend time. And I have the luxury of at times having a bit more time to spend with patients, to be able to really do spend a lot of time talking through the risk benefit balance. But even then, you wonder how well the message has been assimilated. And I think there's so much worry around side effects of things, and it's so easy now online to Google things and become completely terrified about what side effects you might get from a medication. It's an uphill battle. So I don't really have any definite answers. We are exploring different approaches. This radically simple tool might be found useful. The work, Michael and Stuart's work and similar work going on in the UK, I think may well be helpful in that. I think the key thing is to be able to identify people at high risk in the first place, because if we never even see people, to offer them treatment, then what we do after that is irrelevant. So I think trying to get automated systems to identify people at high risk is really important. But yeah, there's a lot of work to do after that to get people to accept treatment and then to stay on it as well. And that's, you know, we all have to do our part in that and do our best to communicate clearly.
Yeah, so maybe, yeah, that was part of the answer for the next question asked by Patricia Clark. She's asking, you know, she's mentioning that the treatment gap in the chronological line is the final step. So in your experience, what is missing before, besides the communications that we indeed know it's very important?
Yeah, I mean, to me, it's having a mechanism whereby you can identify people at high risk. And of course, that's bound up in what one, you know, what one does at the local level, but it's also bound up in national policy. And you know, for example, in the UK, we've just got a grant from the Medical Research Foundation to work with the Royal Osteoporosis Society to look at turning the results of the SCOOP trial, which demonstrated that screening for osteoporosis reduces number of hip fractures, into a sort of national policy through working with our all-party parliamentary group and producing a policy report and so forth. And it's, you know, the subject of the paper led by Eugene around screening in the quality of life, epidemiology and quality of life working group. And I mean, Patricia will be hearing more about that, I guess, in due course. So to me, I think if you don't identify people who warrant assessment and treatment, you know, you're never going to find people to treat. So I think we've got to be working on that. FLS is clearly a part of that, but of course there's many more people out there who are high fracture risk that haven't actually fractured. And if we can find effective ways of sort of automatically, at least in some sort of systematic fashion, flagging those people up so that they can get onto some kind of pathway that results in a FRAX score at least, and then a recommendation for treatment, that would be a major step forward. And I think that that's certainly my priority in terms of thinking. And but we've got to address that. You know, there may be opportunities to address that at local level, you know, through the new integrated care systems that we have in the UK and you know, other health systems in different countries. But I do think it's something that's got to be addressed at the policy level as well.
And maybe the last question, but I think you already answered it, but it's the same kind of question, maybe formulated in a different way. Dr. Yavropoulos was asking if there is a possibility that the treatment gap includes also a diagnostic gap. For example, especially in fracture patients that are not directly treated by surgeons who look for osteoporosis.
Yeah, absolutely agreed, and I think it's really along the lines I've been describing. And yeah, absolutely, I think we need to get the message out across all of the specialties involved. And I think, you know, it's very apparent that for FLS, for example, you know, the interaction between the treating surgeon, if the surgeon is not the person who's going to be doing the osteoporosis care, but the awareness that it's an issue and the interaction between that surgeon and the team doing the osteoporosis care and reducing fracture risk is absolutely paramount. And, you know, linking with pharmacists and therapists and the whole range of specialties involved, it is really important. So yeah, absolutely, there's a lot bound up in the treatment gap, but I think, as I said, identifying people at high risk in the first place, whether that's through them having had a fragility fracture or through getting them systematically assessed using FRAX, is a key first step.
Thanks very much. And now I think it's time to conclude. And I would like to encourage all of you to visit the IOF website, where there is a dedicated web page to this program scope with many resources available, including the 2 scientific publications in open access, an illustrated summary report, and country-specific reports and infographics. I would like now to thank all of you for your participation in this webinar, and we hope that you enjoyed this session. We will post the recording of this webinar on the IOF website, and you will receive the link and the certificate of attendance by email tomorrow. You will also be prompted to fill in a survey immediately after this webinar. We would appreciate your input and comments. And last but not the least, if you have any questions and comments, please do not hesitate to send them over to webinar@osteoporosis.foundation. I would like to thank again Professor Harvey for his outstanding talk, and I would like also to warmly thank Amgen and UCB for their support. I hope you will be with us next month. Goodbye, good afternoon to everybody.
Thank you and goodbye.
Goodbye.